Hello there, welcome to ShineTech's YouTube channel. In this video, we are going to focus on the pathology of the kidney and its collecting system. Specifically, we are going to look at the minimal change disease. So, diseases which affect the kidney are divided into those which affect the glomeruli, which is the filtering part of the kidney, nephron. And then we have diseases which affects the kidney tubules, and we have those which affect the blood vessels of the nephron. Okay, so in this video we are going to focus on the disease which affects the glomeruli. Okay, so these diseases, we have those which are called primary glomerular diseases, which are listed here, and in this video we are going to focus on minimal change disease. Other preceding videos we are going to look at these other conditions. Okay, so apart from primary glomerular diseases, we also have what we call glomerulopathy secondary to systemic diseases, which are also listed here. So we're also going to focus on these diseases one by one. Okay, so without wasting much of your time, let's dive into minimal change disease. So minimal change disease is the most frequent cause of the nephrotic syndrome in children. So this condition is mainly frequent in children. So nephrotic syndrome, this is a disease or a condition in which we have loss of proteins, which is called proteinuria in the urine. We also have what we call hypoalbuminemia, which is decrease in the levels of albumin in the blood. Okay, and minimal change disease is also characterized by what we call glomeruli that have a normal appearance in a light microscope. So if you get a biopsy of a nephron which has this condition and observe it in a light microscope, you are going to observe a normal appearance of the glomeruli. Okay, but if you use an electron microscope, you're going to observe what we call diffuse effacement of podocyte food processes. Okay, so I'm going to explain about effacement of podocyte food processes later. As for now, just know that this condition happens, or it is observed when you use an electron microscope. And mainly minimal change disease occurs mostly in 1 to 7 years of age, okay, in children which fall under this range of 1 to 7 years of age. So pathogenesis. So pathogenesis of minimal change disease is not well known, but there is a suspicion of circulating molecules. So we have these circulating molecules which injure what we call podocyte and cause what we call effacement of food processes, and effacement of these food processes will lead to proteinuria, that is protein in urine. Okay, so in a normal glomerulus, we are going to see this structure here. So we have a glomeruli here. So that is the structure which filters filters waste from the blood. So we have an afferent blood vessel which comes into the glomeruli, and we have an efferent blood vessel or arteriole which leaves the glomeruli. So once the afferent brings blood to the glomerulus, it is going to be filtered. Okay, the waste will be filtered and will leave into the tubules of the kidney nephron, and that blood will continue into what we call the efferent arteriole. So the structure of the glomeruli is what is illustrated here. So the layers which filters the blood has these structures as observed in this structure here. So we have the basement membrane. Okay, so on this structure here we have what we call the glomerular basement membrane in blue there, and we also have the endothelial cells which surrounds what we call the blood vessel. So we have the endothelial cells. Remember, this is the blood vessel lumen, and we have the endothelial cells followed by the glomerular basement membrane, and then we have cells, okay, which are called podocytes. So these are the podocytes. So these podocytes have what we call food processes, okay, podocyte food processes, which are these structures here. Okay, so for any filtrates, okay, to be filtered has to pass through these three layers. We have the endothelial cells, then from there it has to pass through this glomerular basement membrane, and then it has to pass through the pores or the slits of the podocytes. Okay, so those are the slits of the podocytes. But what prevents some of the molecules such as proteins to not to be filtered from from the blood vessel? Okay, so as we know, proteins are larger in size, but we also have very small proteins which are called albumin. Albumin is very, very small, and sometimes it can pass through the endothelial cells, but it cannot be filtered due to this negative charged layer which is on the podocyte food processes. Why? Because albumin is also negative, or proteins are negative, and we also have that negative layer there in the podocyte which repels the negative proteins. In that case, proteins are not filtered. But now, due to this condition which is called minimal change disease in the kidney, we have what we call effacement of food processes. So effacement of food processes, that is wearing off or degeneration of food processes. Okay, so we have these food processes which forms slits which are very small, and also forms that negative charged layer which repels proteins. But in this case, we have effacement, we have destruction of those food processes. Now we are going to observe proteins being lost from the blood vessels into the uh, urine. That is what we call proteinuria there. Okay, so effacement of food processes will lead to proteinuria. So that is the pathogenesis. Firstly, we have circulating molecules such as cytokines and other chemicals produced by T cells and lymphocytes. Okay, we also have candidate serum factors which are produced by the lymphocytes and other cells, but here the pathogenesis is not known. But what is known is that there are some molecules which are produced by T cells, and also we also have these candidate serum factors which are produced by the lymphocytes. So these chemicals, they are going to destroy, they are going to cause effacement of food processes, and effacement of food processes will lead to proteinuria, protein in in urine. Okay, so that's all about the pathogenesis of minimal change disease. In the light microscope, you are going to observe a normal glomeruli, but in using an electron microscope, you will observe effacement of podocyte food processes. Like here, we have destruction of those food processes. As a result, proteins are going to be lost. Okay, so let's move on to the morphology of this condition. So as I've already said, using the light microscope, we are going to have a glomeruli which is normal. Okay, but we have what we call loss of proteins and also lipids, okay, in the urine. Okay, so once they are lost in the glomeruli, in the tubules, we are going to observe what we call heavy laden of with protein and lipids, droplets of lipids, due to reabsorption. So the kidney tubules will try to reabsorb the proteins which have been lost, okay, which have been lost in the glomeruli. Okay, so in that case we are going to see heavily laden protein droplets and lipids, okay, due to that reabsorption process. Okay, and we also are going to see, as I've already said, the diffuse effacement of food processes of the podocytes, and we have the cytoplasm of the podocytes will appear to be flattened, okay, over the external aspects of the glomerular basement membrane. Then apart from that, we have other morphologic features such as vacuolization, where we observe vacuoles in the podocytes. Then we have microvillus formation. Okay, so these microvilli are formed on the podocyte as well, and we have occasional focal detachments. So podocytes food processes will be detached from the basement membrane of the glomeruli. And then we also have injury to podocytes. So these are the morphologic features which are observed in minimal change disease. So moving on to clinical features. Under clinical features, okay, so we know that this minimal change disease is also a nephrotic syndrome. So minimal change disease will lead to development of nephrotic syndrome in otherwise a healthy child. So in a healthy child will develop what we call nephrotic syndrome due to minimal change. Then from there we have hypertension is not observed. Okay, so in minimal change disease, hypertension is not observed. Okay, so the renal function is also preserved. The kidney will be functioning very well. Okay, and the protein loss is usually confined to smaller proteins, more specifically albumin. So albumin is what is lost in urine, and that is why it is called selective proteinuria. Selective proteinuria. Why? Because we only have one type of protein which are lost in urine, that is albumin. So it is selective. Non-selective, that is we have more than one type of protein which is lost, so that is non-selective. But in this case we have selective proteinuria. Then apart from that, the diagnosis, the prognosis for children with this disorder is favorable, and in most cases 90% of children who suffer from minimal change disease are treated using what we call corticosteroid therapy. So they respond well to corticosteroid therapy. Okay, but proteinuria may reoccur even when you are on corticosteroid therapy. When you have been treated, there is a chance that proteinuria may occur. So thank you so much for watching this video. If you like the video, please click on the like icon and subscribe to this channel for more videos like this, and leave your comment what you think about this video.